My talk today about convulsion with pregnancy. As we know, convulsion with pregnancy is the commonest cause of convulsion with pregnancy, including epilepsy with pregnancy. What's the definition of epilepsy? It is a recurrent attack of spontaneous seizures due to sudden excessive disordered electrical discharge from the neuron of the cerebral cortex. Complicating pregnancy is about 6 per 1000 pregnancy are complicated with past or current history of epilepsy. Regarding the classification, it's classified into according to the clinical type of seizures and the specific EEG features. These seizures may be partial or focal seizures or generalized seizure. Partial seizures, it is a localized area originating in the brain, affect the localized area of the neurological function. It is believed resulting from trauma, abscess, or perinatal factors. However, a specific lesion is rarely demonstrated. Can secondarily generalize reduced loss of consciousness and convulsion. Generalized seizure involves the cerebral hemisphere. Both cerebral hemisphere may be preceded by aura, and this is characteristic features for epileptic fits, which may be grand mal, tonic-clonic seizures, and petit mal absence A with absence seizure. The grand males is loss of consciousness followed by tonic contraction of muscle, rigid posturing of the clonic contraction of all extremities. This tonic-clonic. Return to consciousness is gradual. The patient may remain confused, disoriented for several hours. Immediate recovery of consciousness or orientation, such seizure may pass unnoticed by the others. About 25 of patients with petit mal develop the grand mal seizure. Diagnosis: this woman has diagnosed before pregnancy. The first seizures occur during pregnancy. Wide differential diagnosis. So it is with pregnancy you must do CT scan, preferably MRI, reviewed by the neurologist. Differential diagnosis of seizure convulsion during pregnancy: idiopathic, may be secondary to specific cause like trauma, intracranial mass, and phospholipid syndrome, gestational epilepsy secondary to pregnancy. Vascular disease like eclampsia, hypertensive encephalopathy, cerebral vein thrombosis, thrombotic thrombocytopenic purpura, subarachnoid hemorrhage, and cerebral infarction. All this may be differential diagnosis with convulsion with pregnancy. Other causes including metabolic disorders such as hypoglycemia, hypocalcemia, hyponatremia, liver and renal failure, anoxia, and alcoholic withdrawal. Cephalitis, brain abscess, subdural empyema, cerebral malaria, drug toxicity like lignocaine, local anesthetics, amphetamines, lithium, and pseudoepilepsy. The effect of epilepsy on pregnancy: 15%. Women with poorly controlled epilepsy or multiple seizures who suspected or stopped medical medications at higher risk increase the seizure frequency. So it is maybe unchanged or increased or decreased. It depends according to the medication stopped or take adequate medication or not. What is the effect of pregnancy on epilepsy? No relation to the seizure type or the course of epilepsy during a previous pregnancy. Risk of seizure is highest in the peripartum period. Epilepsy is common indirect cause of maternal death. In many deaths, the cause was aspiration or epileptic seizures may be fatal. The effect of pregnancy on epilepsy not known whether it increase or the risk of unexplained death. The risk factor including high seizure frequency, increase the number of anti-epileptic drugs, low IQ, and early onset epilepsy. The effect of pregnancy on epilepsy: possible reason for deteriorations. Pregnancy itself from the anti-epileptic medications decrease the level of anti-epileptic levels, and this is very important. due to the nausea, vomiting, and the hemodilutions, lack of sleep, lack of absorption of anti-epileptic treatment, and hyperventilation during labor. This is as possible cause of deterioration of seizure during pregnancy. Epilepsy, maternal epilepsy is associated with higher risk. 10% if there is previously affected child. 15 to 20% if both parents have epilepsy. The effect of pregnancy, epilepsy on pregnancy leads to short period of hypoxia. There is no evidence that the effect of this single seizures on the fetus, but if it is repeated, actually it leads to affection of the fetus, and it is also leads to fetal bradycardia during the maternal tonic-clonic convulsion, but there is no long-term cerebral hemorrhage. The other effects of epilepsy on pregnancy, there is no increase the risk of miscarriage or obstetric complications. If there is a status epilepticus, there is a dangerous for both the mother and the fetus. What about the teratogenic skills of anti-epileptic treatment? We have and classification according to their ability to induce liver enzymes, enzyme inducer like tigratols, phenytoins, phenobarbital, and this enzyme inducer. Non-enzyme inducers like sodium volupurate, dibakine, or lamotrigines, gabapentines. The commonest used here is tigratols, phenobarbitons, and dibakine. Of this increase. However, the benefit of seizure control during pregnancy outweighs the risk. Polytherapy anti-epileptic drugs carry a greater risk, so monotherapy is preferable. The teratogenic risk of anti-epileptic drug includes major anomalies like cleft palate, cardiac defect, neural tube defect, microcephaly, intrauterine growth retardation, developmental delay, and the minor abnormality like hypertelorism, distal digital nail hypoplasia, low set abnormal ear, flat nasal bridge, epicanthetic fold, long fulcrum. Teratogenic risk of anti-epileptic drug with anti-epileptic drug carries a risk of fetal harm, which is it, such as newer drugs such as gabapentine are not teratogenic in animal, but there is a few data according to the use of human pregnancy. So we remember that we use all the traditional treatment. We don't use the newer drug for as anti-epileptic. We continue on the previous medications and we monitor the therapeutic dose according to the change that occurred during the pregnancy. What about management? Pre-pregnancy counseling, diagnosis reviewed by the neurologist, optimization of the treatment, achieve seizure controls, use the least number of medication. As I say, the monotherapy is better than polytherapy. The least medications, the idea is to use the lowest dose to control seizures. Pre-pregnancy counseling includes stopping drug if the seizure is free for at least 2 years. All women should take folic acid, very important, 5 milligram per day for at least 12 weeks before conceptions. Continue until delivery. This decreases the risk of neural tube defect and decreases the risk of epilepsy in the child. So, again, folic acid intake by the dose of 5 milligram per day. This differs from the supplementary dose during a normal pregnancy of 400 microgram. This is 5 milligram per day. Prenatal screening, alpha fetoprotein for neural tube defect, detailed anomaly scan, exclude facial cardiac anomalies. We can do fetal echo by 22 or 24 weeks. Antenatal management, we add vitamin K 10 milligram per day for at least 4 weeks of pregnancy. All steroid to be given for the usual obstetric indications. Woman taking the enzyme inducer anti-epileptic treatment should given 48 milligrams in total. 2 doses of dexamethasone 24 hours apart. Antenatal management, avoid sleep deprivation. There is no rule of routine monitoring of drug, but it may be useful in women with increased seizure frequency, suspected non-compliance, concern over toxic side effect, and polytherapy. Vaginal delivery should be the aim. Cesarean section should be for obstetric indication. Seizures is not an indication unless there is a status of epilepticus or recurrent seizures in labor that may warrant cesarean section for fetal reasons. So, vaginal delivery should be the aim and cesarean section for fetal reasons. Intrapartum care, every effort must be made to administer anti-epileptic treatment like IV phenytoin can be used if necessary, although it may cause arrhythmia. Seizures during labor are best controlled with intravenous benzodiazepine. Postpartum care, vitamin K, 1 mg intramuscular to the neonate. Why? To prevent the neonatal hemorrhagic disease. Anti-epileptic treatment may rise in the postpartum period. Monitoring may be necessary to prevent side effects. If doses have been raised during pregnancy, reduction in the immediate postpartum period may be necessary. Postpartum care, anti-epileptic treatment, reach the breast milk. Breastfeeding should be encouraged. Neonatal side effects are rare, but sedation's withdrawal effect must be watched for, particularly when phenobarbital or benzodiazepine. So the fetus may develop withdrawal side effect. Anti-epileptic may be enzyme inducer, so it decreases its efficacy. Ibuprofen should be given every 10 weeks instead of every 12 weeks. Mirena is ideal. Locally given progesterone will not affected by induced liver enzymes. On conclusion, epileptic women can get pregnant. They have no different than other women. Epilepsy and its medication increase the incidence of congenital malformation 2 to 3 times. Chance of having a normal child up to 90%. The most common malformation is cleft lip, cleft palate, congenital heart disease. A woman should not stop anti-epileptic treatment unless she hadn't seizures more than 2 years. Gradual discontinuation can be attempted. Pregnant should not stop her anti-epileptic since most of the malformation develop during the first trimesters. Current anti-epileptic treatment are considered to be necessary even until newer drugs become available. However, the safest is phenytoin and phenobarbital, and we have risk drugs like dibakine. But we continue the treatment and do not change, and the changes are those according to the serum concentrations and the response of the patient. All of us know eclamptic fits associated with convulsions associated with preeclampsia. This tonic-clonic convulsion, how can we differentiate it from epileptic fits? There is a history of anti-epileptic treatment. This is, the epileptic fit per se is preceded with aura. But the eclampsia the patient has hypertension without proteinuria. They develop the tonic-clonic convulsion on top. We remember the management of preeclampsia is brief control and determination in with severe cases. Patient position in his left side, her sides, and we try to aspirate, maintain oxygenation, intravenous access, catheter, monitor of the diastolic blood pressures. Don't forget that determination is ideal treatment after brief control. We finish epilepsy. The second commonest cause of convulsion during pregnancy is eclampsia. Because we just remember eclampsia. Preeclampsia, in addition to presence of convulsion, we need team approach, OBG specialist, anesthetic, pediatrician, physician, nursing staff, and blood banking personnel. An additional medication takes such as magnesium sulfates. This is the mechanism of action of magnesium sulfate. It is a courier-like action. The weak CNS depressant decrease prostaglandin I2 productions, decrease platelet aggregation. This is the dose of magnesium sulfate. Start by during dose, then after that continue maintenance dose. Monitoring of magnesium sulfates by the respiratory rate, the urine output, the tendon reflex. In the presence of tendon reflex, urine output must be more than 30 milli per hours, and the presence of patellar reflex. We note that the magnesium sulfate has a cumulative effect, so we maintain the therapeutic levels 4 to 7 milli equivalent per liters. This is a serum level of magnesium sulfate according to the manifestation. So the highest narrow is a narrow limits between the therapeutic and the overtoxic dose of above 15 milli equivalent per liter leads to cardiac depressions, and from 10 to 15 leads to respiratory depression. So this must be good monitored. By the end of my lecture, we summarize the causes of convulsion with pregnancy in the following. Number one, eclampsia, commonest cause. Number two, epilepsy, hysteria, cerebral convulsion, including meningitis, encephalitis, brain tumor, intracerebral hemorrhage, uremic convulsions, tetanus, tetany, strychnine poisoning. So this is the commonest, again, this is the commonest cause of convulsion. Commonest one per se, eclampsia and epilepsy, and this must be differentiated, as I said before. This other cause must be also put in the differential diagnosis. Thank you.